Hello, everyone, and welcome to the Aplastic Anemia and MDS International Foundation continuing podcast series. We're coming to you today thanks to generous support from individuals, donors, and our corporate partners, including Celgene. My name is Alice Hauk. I'm the Senior Director of Health Professional Programs for AAMD-SIF, and today we're chatting with Christina Cline, who is the manager of the University of Florida Malignant Hematology Division. Although she's been working in clinical research since 2004, even before she earned her RN, BSN, and CCRC, she is now the study coordinator for Industry Investigator-Initiated and the NCI National Cancer Institute Cooperative Group studies at University of Florida, as well as Phase 1 trials. Christina continues to devote herself to the many participants who voluntarily engage in clinical trials, all of whom contribute to making a difference in the lives of future cancer survivors. Welcome, Christina.
Hi, thank you for having me.
We understand in your short bio that you've been interested in clinical research for 15 years. What first drew your attention to this field?
Well, it's very interesting that you asked that question. I kind of just fell into the lap of research. I previously had worked at a blood bank, and I applied for a position in research that was a temporary position. It was more of an administrative assistant type position. And so I got hired on into that position. And as I began learning my role in that office, I started working very closely with the clinical trial nurses that were on the heme malignancy floor. And I started really just becoming a part of their daily workflow. I started watching their interaction with patients, how they educated them, how they helped facilitate their care with the healthcare team in accordance to protocols that patients were voluntarily participating on. I watched them advocate for patients and really become an intricate piece to the overall treatment of the patient's care and their diagnosis. And with that, I was really encouraged by these trusting relationships that were being developed and maintained throughout the course of the care, that I started to really develop a passion for clinical trials and what clinical trials did. And watching these patients voluntarily participate in these trials, I was seeing how science was helping to provide new treatments and access to novel therapies and overall trying to improve quality of life for patients living currently with cancer and for those in the future. So I started to just really get involved and started to learn protocols and eventually worked my way into being a clinical trial coordinator myself, and then went back to school to get my nursing degree. And so I obtained my RN and then got my bachelor's. In the meantime, still stayed involved in research. And I did a little bit of time on a pediatric oncology floor as a bedside nurse. And then I went back into the lap of research and started coordinating Phase 1 trials. And it's been such an amazing journey being a part of the many lives that I have been allowed to be a part of, and then also watching certain medications and certain therapies that initially started out in a clinical trial that are now being used as frontline therapy to treat patients with certain types of heme malignancies, such as leukemias, that are able to get them into a remission where they have quality of life. So I developed this huge passion through just watching my colleagues basically on the floor. And I've been here ever since, just the patient population. And I've just developed a deep love and privilege to be a part of this with them.
Well, that is a very impressive journey. You've seen it from all levels for a number of years, so we can see why you're so dedicated to the field and to your role now. When did you become interested specifically in hematological malignancies and the challenges that those pose?
I always had worked in heme malignancies. So initially that's where I started. And the more I learned about the different types of diseases that can evolve with bone marrow failure and working with our clinicians in just how they treat these types of bone marrow failures, I just stuck with this, and leukemia actually became the leukemia and MDS became the disease process that I actually found more passionate about, and that's where my specialty lies. So I work very closely in trials that are targeting, looking at better treatments to improve those types of bone marrow failures, looking at now through certain genetic mutations that are where we're kind of changing the face of how we treat these types of diseases by targeting certain gene mutations now and kind of personalizing the targeted therapy more for this patient population. I have always been in heme malignancies, but I have collaborated some with some solid tumor and pediatric, just collaborating with some of the patient population, but most of my specialty has lied with MDS and leukemia patients.
And as you said, the personalized treatment is becoming the way. It's not of the future; it's of the present, and that must create new challenges for you to keep up with all this new information. How do you do that there in your division?
Well, we do a lot of education and we watch a lot of webinars through the Leukemia Lymphoma Society. We do, there's a lot of education that takes place with the physicians as well. I even see the physicians are learning more about these certain targeted therapies and these certain gene mutations as well. And I have the privilege of working with Dr. Kogel, who is very knowledgeable in genetics. And so he does a really good job of educating us so that we can learn about these new genes and these new therapies that are targeting those specific genes.
And with the bone marrow failure diseases that you see, you have mentioned myelodysplastic syndromes and leukemia. Are there other hematologic related diseases, the bone marrow failure diseases that you see in your division as well?
Yes. So we see a number of different disease types. We work with acute lymphoid leukemias, acute myeloid leukemias, multiple myeloma, myelofibrosis, and as well as lymphoma that has bone marrow transplant involvement, to where the treatment now is no longer working for their disease, and so now they have to undergo a bone marrow transplant. And then we also have a bone marrow transplant program here, which is to treat a variety of different bone marrow failure diseases, including aplastic anemia and sickle cell, to where we basically, it's like you're taking out the old soil and you're putting in the new soil so that you can grow a new immune system, a healthy new immune system with no cancer cells, hopefully, and then move forward with an improved quality of life.
And many of your patients, of course, are participating in a clinical trial or considering enrolling in a clinical trial. Can you explain your role in that process and how you prepare patients to consider a clinical trial and then ultimately prepare them for participating if they choose to do that?
Yeah, so initially when a patient is transferred or referred to our center, the medical records are reviewed by the doctor. And then the doctor typically reaches out to the clinical trials team to evaluate the patient for any potential clinical trials. And this is so that we are able to offer the patient all potential options for the treatment so that the patient is able to make an informed decision that is best for them in regarding their care, also their social economic status that may be occurring. And so we want to offer them all of their potential options. And so the clinical trials teams looks at basic eligibility, such as disease, the current stage of the disease, their age, and any existing comorbidities. If the patient is eligible for any clinical trials, the clinical trials team then communicates and discusses that with the doctor, who then in detail discusses that with the patient along with the standard of care treatments and the potential clinical trial that they may be eligible for. And then if a patient is interested in the clinical trial, the doctor then informs us, and then that is when we are introduced to the patient. And when we are introduced to the patient, that is when we begin the informed consent process, which is an ongoing process that takes place throughout the initial meet and greet until they have completed treatment on a clinical trial. And with the informed consent process, we discuss with them the purpose of the trial, the potential benefit, the intervention, the study procedures and schedules, the risk, the voluntary nature, and then we are answering any questions throughout the discussion. And they typically have a number of days to think over, to look at this consent, discuss it with their family members, call us back if they have any questions or concerns. And then when they come back to their appointment, they then discuss it further with the physician. And if they're interested in the trial and all of their questions have been answered, then they would consent to the trial with the physician. And then once they consent to the trial, that's when screening procedures and things like that would start to see if they are eligible to continue to the treatment that the trial is designed to provide. And so we do a lot of educating and explaining of not only just the types of therapies that may be involved in a clinical trial, but also just taking the time to sit and discuss with patients standard of care therapies. So one of the privileges of being a clinical trial coordinator is that we have time to sit with the patient and really listen to their concerns and answer their questions and give them the information to help them make the best decision in regards to their care. And so once they, decide that they do want to participate on the trial, we then move forward and continue to educate them and step by step, continue to inform them of what is happening next. This is what is going to happen at your next cycle. And these are the days that we'll be asking you to come in and working with the healthcare team to get you scheduled. These are the types of procedures that are going to be occurring. And at any time that patient decides that they want to withdraw for whatever reason, then we're here to help facilitate that to where we can safely remove them from the clinical trial as well. But the importance of informed consent, it's so important. It's one of the biggest things that I'm very passionate about because I want to empower the patient to make the best decision in regards to their care.
And what do you find are some of the most common concerns or questions that patients and families have in the process of this discussion about clinical trial participation?
Many of them want to know, why do researchers believe that the treatment being studied may be better than the one being used now? Which is a great question that I always encourage them to ask the doctor too. Why may it not be better? How long am I going to be in the trial? What kinds of tests and treatments are involved? Will I be told about trial results? That's a really common question that we get asked by our patients as well. Is there someone I can talk to who has been in the trial? They also are, it's really important for them to know what their rights are, to know how do the possible risk and benefits of the trial compare to those of standard of treatment. Some other common questions are related to cost. Will I have to pay for any of the treatment or test? What costs will my health insurance cover? Who pays if I'm injured on the trial? Who helps answer any questions from my insurance company? So those are some types of questions that are asked very commonly. And then, of course, what happens if I decide to leave the trial? And I think it's really important for patients to understand that their participation is completely voluntary and that at any time they feel that they need to, that this trial is maybe not something that they can continue on, that their participation is voluntary and that it is okay if they decide that they want to withdraw. It also is okay if they decide that they do not want to participate. And that's another, great part of our role is that we can help advocate for them. If a clinical trial just doesn't work with their schedule, with their home life, with some of the things that they have socially going on, we're there to help facilitate that so that they can still get the best treatment possible for the treatment of their cancer.
And with their preparation for clinical trial participation, what are some of the things that you look for? Like, what are some of the screening procedures that are done to help determine if they are eligible for the clinical trial?
A lot of basic eligibility is going to be the status of their disease. Is it a newly diagnosed type of disease process? Is it a relapse refractory disease process? What kind of treatments have you had in the past? Or how many lines of therapy have you had in the past? We want to evaluate the heart to make sure that the heart is functioning properly and that there's no abnormalities with your heart. We want to make sure that your lab value ranges are good. Are your kidneys functioning correctly? Is your liver working correctly? So there's a lot of those types of procedures that take place. Sometimes trials may request chest x-rays or scans to be done so we can, depending on the type of disease process you may have, like multiple myeloma patients, we want to look at their bones and we want to see if they have any lytic lesions on their bones. AML patients, we want to, look at a lot of blood labs, their hematologic blood counts. What's your white blood cell count? What's your neutrophil count? What type of blast do you have? And so there are a variety of different tests that are performed in screening, but overall these tests are performed to make sure that it is safe to move forward with this patient receiving this type of treatment for their type of disease.
And what are some of the types of clinical trial treatments that you've seen that you conduct there at University of Florida? And if you could explain just a little bit about the different types that patients need to consider at some point in their disease journey.
Yes. So we actually, our center participates in many different types of clinical trials, ranging from industry trials to trials performed from the National Cancer Institute and cooperative group trials. And we also have faculty-developed trials here at the University of Florida, ranging from phase 1 to 3 trials, some targeting specific gene mutations or disease processes such as leukemia, myelodysplastic syndromes, aplastic anemia, lymphoma, myeloma, and other bone marrow failures. When you look into the different phases of clinical trials, when you look at a phase 1 clinical trial, we're primarily looking at safety. The purpose of the trial is to identify safety in the dose. Doses are typically adjusted to determine how much of a drug the body can tolerate and what side effects can emerge from the course of treatment. The purpose of a phase 1, though, is not to benefit the patient or affect a cure, but what we're wanting to identify is, what is the safest dose that it can be administered. And approximately 70% of new drugs complete phase 1 and move on to phase 2. And those are typically performed in a very small population of patients. They are closely monitored, appointments, vital signs, ECGs, labs, and to gather this information about how the drug interacts with the human body. And then once that dose is identified, it then can move into a phase 2 clinical trial, which we're looking at how well does the treatment work. So phase 2 trials continue to test the safety of new agents based off of information obtained during the phase 1, and we begin to evaluate how well the drug works against the specific type of cancer. So basically, what is the purpose, the efficacy, and the side effects? How does the treatment work? How safe is the treatment? This is where we're documenting things, all potential side effects that patients may be having, such as nausea, headache, muscle pain, anything that is not part of their baseline side effect. Approximately 33% of those drugs actually complete phase 2 and then move on to the phase 3 trial, which is then performed in a much larger population. We're looking at hundreds to thousands of patients that could be enrolled in phase 3 types of trials, multiple sites that could range from the United States and even internationally. And phase 3 is focusing on learning whether the treatment is better than, the same, or worse than the current standard treatment. And these studies typically utilize a randomization type process, blinding stratification process. to where a placebo could be used, but a placebo would not be the only drug that is being administered. No matter what, you would receive some type of standard of care therapy with the addition of an investigational agent or placebo, but you would still receive a standard of care therapy. Or it could look at two types of arms. Here's a treatment arm with an investigational therapy versus a standard of care arm. And the purpose of these are efficacy and, again, monitoring of adverse reactions. Is the treatment potentially of benefit to a specific population, and confirming through a large-scale data collection that the treatment is safe? And then approximately 30% of drugs complete phase 3 and then move on to phase 4. And phase 4 is typically occurs after a treatment has been FDA approved and looks at long-term safety and effectiveness. We also do some combined phase trials here, which look at phase 1-2 or phase 2-3, which is a combined design within a protocol that enables a transition between the trial phases and may increase the efficiency in answering certain questions. We also do some PI-initiated trials where there are some certain science that can come from the bench in a laboratory and then can be used first in human. And those typically start off as phase 1, but they can be developed through our own institution with our own physician.
Thank you. That was a very clear and comprehensive description of clinical trials, because it can be very overwhelming for patients to understand the phases as you describe them, and also how very long it can take for the process of drug development. We all wish that there were faster answers and decisions made about the efficacy of drugs, and this process is designed to ensure the safety of the patients all the way along, and also if it really is making a difference before it's taken any further. So I'm sure you get questions about that from patients as to why it takes so long, but your description there of the phases and the entire process was very helpful to give some reasoning for why it does take so long.
Yeah, sometimes those trials can take 10 to 15 years before a drug is actually approved from the phase 1 portion.
You described PI clinical trials. PI is a principal investigator. Is that the correct term for that acronym?
Yes.
So that can, as you said, that can be generated by a physician in your own institution, and in addition to outside groups or collaborative ones that you participate in.
Yes.
Okay. In all of this, we've talked, of course, about the role of the clinical trial team and explaining everything to patients and caregivers. What is the role of the caregiver in helping the patient decide if participation in a trial is right for them? And also, just throughout the trial, what role does the caregiver play in your experience?
I feel like the caregiver plays an extremely important role. Many caregivers help get patients to and from their appointments. Many caregivers keep track of when these appointments are and when they need to be scheduled. They help patients deal with certain side effects that they may be receiving from these drugs that they may be receiving. If patients are receiving oral medications as an investigational agent through a clinical trial, they help ensure that these patients are taking their drugs on time, that they're following directions at which they need to be administered, whether they're administered with food or on an empty stomach. Do you drink a glass of water? Do you stay away from grapefruit juice? So I almost feel like the caregivers wear so many hats. They're like the air traffic controller. They just make sure that the patient is safe, and they also help communicate some of the patient's needs when the patients aren't really feeling good. I do see that sometimes patients tend to not always want to express some of the things that they may be feeling because they don't want to come off of a clinical trial for some reason. And sometimes that caregiver is there to advocate for that and to share some of that information. And so I feel like the caregiver plays an intricate role in the care of a patient who is going through this journey in their fight towards cancer, and communicating and working very closely with the clinical trial team as well as the healthcare team, and making sure a patient is safe and taken care of.
So, as you said, that is an extremely important role and difficult for patients if they don't have a support person or a support team around them, really, even beyond the clinical setting.
Yes.
Another question about the clinical trials that you conduct. I understand one of them, or some of them that you conduct, are related to preparation for transplantation, if that's a possibility for a patient. Can you talk a little bit about those types of clinical trials and what those are, what the intent of clinical trials for preparation for transplant are?
Yes. So we participate in the Bone Marrow Transplant Clinical Trials Network Cooperative Group. It is funded through the National Health Institute, and many centers within the United States participate in this huge cooperative group trial. And there are many trials that are targeted specifically for transplant and how we can improve transplant outcomes. Many patients who undergo transplant, depending on the type of graft source that they may be receiving, which is, would you receive a transplant through a matched unrelated donor through the NMDP? Would you receive a transplant with a sibling who might match fully or even be a half match? You could also receive a graft source through a cord blood transplant. And so there are many different graft source types that we can treat a patient to prepare them for transplant. But what happens after transplant is that there is a condition called graft versus host disease. It can be acute, meaning that it occurs within the first 100 days of your transplant, or it could be chronic, meaning it occurs beyond that 100-day mark of transplant. And what it is when you receive your transplant, your body then becomes foreign to the cells that are infused in your body. Those T cells that are infused say, hey, wait, this is not my body and you do not belong here. And then they kind of like have a little war going on to where your body and your graft source are kind of fighting each other to see who's going to actually take over in the house. And so that is called graft versus host disease, and you can receive that through many different areas. You can receive it, graft versus host disease can develop on the skin, where you can develop a rash that is red and itchy and raised. Your liver can also feel the effects of graft versus host disease, which is monitored through evaluating your liver enzymes through lab blood work. Your gut can also develop graft versus host disease, and patients can develop nausea, diarrhea to very extreme ranges of these conditions. And so there are many trials that are targeted to either reducing the development of this acute graft versus host disease, and so the conditioning regimens at which you are prepared to administer to get you ready for transplant, that is given to actually wipe out your bone marrow and then get your body prepped to have these new cells infused. And so part of that conditioning regimen, graft versus host disease drugs can be given to prophylactically prevent severe GVHD. And so there are treatment trials developed to include certain drug regimens that can help do that. Then there are also trials that are designed to actually treat graft versus host disease if it is developed in the outpatient setting once you're discharged from the hospital within that 100 days. And there are certain drugs that are being developed to help treat that to minimize side effects of graft versus host disease. And so graft versus host disease is we've come a long way in how we treat it and how we reduce the complications of it. But at the same time, you still want a little bit of that graft versus host disease, because that way those T cells can eat up any minimal residual disease that may be floating around that may not have been completely wiped out by the chemotherapy. So with the bone marrow transplant trials, we have trials that can help treat or try to reduce graft versus host disease. And then we also have trials for lymphoma patients that try different types of conditioning drugs to get these patients prepped for transplant so that they can have a better outcome once their new immune system takes place and develops.
That's very extensive, and I think that's helpful for patients to understand the options for them in preparing for a transplant and all the different approaches that are available now and that are being, of course, tested in clinical trials as well. But I think that's very encouraging that there are so many avenues for them to take now, and with very strict oversight and care at a medical facility that they trust, and that they trust in speaking with the team if they have concerns. Finally, Christina, we know obviously you care deeply about your patients, and you've spent many years in this field and in particularly with an interest in research. What are some of the key messages you would want all patients who are considering participating in a clinical trial or who are in one now to understand about their participation and how important it is for the future of bone marrow failure disease treatment?
Well, participating in a clinical trial is voluntary. And so for those who do decide to participate, it is an honor and a privilege to be a part of that journey with them as they give their time and give all of this information that allows us to collect data to improve the treatments for cancer and quality of life for patients. And, there was this chart that I saw a while ago that in 1975, there were 3.6 million cancer survivors. And in 2016, there were 15.5 million survivors. And in 2040, it's projected that there will be 26.1 million cancer survivors. And I truly believe this is all part to research, and most importantly, to those who were giving and are also still giving of themselves to participate in clinical trials to help win the fight against cancer. And so through our participants that take the time to participate in clinical trials, we are developing newer therapies that can hopefully reduce toxicities and improve quality life for patients that are in this fight against cancer.
Thank you, Christina, for explaining more about clinical trials for bone marrow failure patients and their families, and sharing some of your years of experience in working in this field. And thank you, listeners, for being with us again. Remember, you can find out more about all types of bone marrow failure diseases on our website at aamds.org, through social media, at AAMDS on Instagram and Facebook and other sources you may consult. And also we have an opportunity for you to chat with your peers online at marrowforums.org. We'll see everybody next time. Thank you again for your time.